Module 5 is Chapter 11 in your F.A. Davis book, which is about respiratory disorders and pediatrics. So the first thing we are going to talk about is developmental differences in the respiratory system of a child versus an adult. So one of the things that is different is that their upper airway is shorter and narrower than an adult's. So basically, if we're looking at like the upper trachea and larynx area, it's shorter and narrower because, of course, the child is just smaller in general. So if we're talking about a newborn, their airway is only approximately 4 millimeters in diameter, which is obviously very small. So this can become a problem if they do have inflammation in their airway. So if their airway is only inflamed, say 1 millimeter, that's going to decrease their airway by 50% because it's going to be all the way around the diameter of the airway. Another thing that we have learned before is that newborns are obligatory nose breathers until around 4 weeks of age. So basically they want to and need to breathe through their nostrils versus their mouth. Also, another thing that we can expect is that since they have irregular breathing, we can expect them to possibly have apnea up to 15 seconds. So up to 15 seconds is considered normal in the newborn period. Anything over that may be cause for concern. Another difference is that the larynx, which the larynx is where the vocal cords are, is more flexible and it's more easily stimulated to spasm. So this can become a problem if the patient is sick for whatever reason, say they have RSV and they're having spasms in their vocal cord area, it can basically cut their airway off. Also, the cartilage in that same area, like the thyroid cartilage and the cricoid cartilage, are more flexible. So we need to make sure that the head and neck are positioned properly. Because of this extra flexibility, it can actually cut off the airway because it's so flexible. So we want to make sure basically that their neck isn't cutting off their airway at all by their positioning. Also, like we learned before, they have a lot of abdominal wall movements with their respirations. So not only just their chest is moving, but their abdomen is moving as well. One last thing is that infants and small children's metabolic rate is much higher than adults. So since their metabolic rate is higher, they need more oxygen. So since they need more oxygen, that means they need to breathe faster. So that is why children have a higher respiratory rate than adults. When we are talking about assessment of the respiratory system in a child, it is very similar to an adult. So we can ask general history questions, of course, like does the child have any history of any respiratory disorders like asthma or cystic fibrosis or anything like that? What are their signs and symptoms? What are they here for? Is it respiratory related? When we are inspecting, say, the chest, we want to look for things like chest symmetry, just like an adult. A very small child under the age of 2 can appear barrel-chested, which is normal. And then around after the age of 2, it becomes less apparent. Skin, nail, mucous membrane color is the same as adults, with the exception of the acrocyanosis that is normal up to 48 hours after birth. Work of breathing, of course, we want to be easy and non-labored. Children can have nasal flaring and retractions, which is a little more common than in adults. If the adult's very thin, you could see retractions. And also, of course, tachypnea if they are air hungry. Clubbing is a little more rare in children. You could see it in children that do have a chronic respiratory disorder, especially something like cystic fibrosis or if they have extremely severe asthma, but more for an older child. When we are auscultating a child's breath sounds, the sounds that we're going to hear are very similar. So adventitious sounds such as crackles, also sometimes called rails. Remember, those are the crackling or popping noises that are usually heard on inspiration. It happens when air is moving through fluid-filled alveoli. So examples could be things like the child has pneumonia. These sounds usually don't clear after coughing. So even if the child coughs and we listen to them again, we're still going to hear the crackles. Rhonchi or rhonchi, however you want to pronounce it, is a low-pitched snoring-like sound. This is where air is moving through thick secretions, so it could be through things like if the child has RSV or if they have cystic fibrosis or also pneumonia. These sounds may actually clear after coughing. Then we have stridor, which is a high-pitched crowing-like sound that's heard on inspiration in the upper airway. So this you can hear sometimes without a stethoscope, or sometimes even placing your stethoscope on the child's neck, which I know we usually don't do, or even the upper part of their chest, depending on wherever an obstruction is. So sometimes it can be obstructions, like if the child has swallowed something that they should not have swallowed and it's obstructing the upper airway. It can also be, it's also common in conditions such as croup, which we'll talk about later. Wheezing, of course, is another sound, a high-pitched musical sound that is heard through respirations. So it's where air is passing through constricted bronchioles or a narrowed airway, such as in asthma. Also, when we are assessing the respiratory system, we could percuss, even though we probably aren't going to, but if we were, we would want to hear resonance. If we heard tympany, that could be a sign of pneumothorax. If we hear a flat or dull sound, that could mean that they have consolidation, which consolidation is basically where something is taking the place of air. So it could be like mucus or fluid, so something like pneumonia. And then if we hear hyperresonance, that could be heard in the presence of asthma. We probably will palpate, maybe not directly in line with respiratory, but it could be related things like assessing lymph nodes. So we could be palpating lymph nodes in the head and neck. That could be enlarged because of infection. We could also palpate for tactile fremitus, which tactile fremitus is the vibrations that we can feel on the chest when the child is speaking or making sounds. So this tactile fremitus could increase if the child has pneumonia. So basically you would feel sort of more vibration, or it could be absent in the presence of pneumothorax. We can also, of course, check pulses, so related to the cardiac assessment, because if a child is in severe respiratory distress and they have decreased perfusion, that could result in weaker peripheral pulses. So the difference between respiratory distress and respiratory failure in children, the respiratory failure being sort of the more severe of the two. But respiratory distress, the child will have tachypnea, dyspnea, nostril flaring, use of accessory muscles, retractions, so it could be anything like intercostal retractions, substernal retractions, subcostal retractions. They could have intermittent coughing, meaning that they're not coughing constantly, but they are coughing on and off. Adventitious breath sounds, so it could be any of the ones that we talked about previously, like crackle, stridor, wheezing, etc. They can have tachycardia, hypoxia, but they're still able to speak. So maybe you put the pulse ox on them and they're satting 85, but they are still able to either speak or have a strong cry if it's a baby. Whereas in respiratory failure, we're getting to the point where the child cannot breathe on their own anymore, or they're getting to that, almost to that point where we're going to have to intubate them. So at this point, their symptoms get a little worse. So they might have mental status change where either they are confused, extremely irritable, or possibly extremely lethargic. They could have cyanosis around their mouth or mottled skin color. They could start grunting, which sometimes sounds like crying if it's a baby, but it's more of a sort of grunt sound, which means that they're having trouble breathing. Head bobbing, which is sort of like accessory muscle use, and it results in the head sort of bobbing up and down. They may be coughing continuously or nearly continuously. They may still have retractions, but they may be moderate to severe. They may be extremely hypoxemic at this point. They may also still have tachycardia, but even higher tachycardia than before when they were in respiratory distress. And at this point, they may not be able to cry or talk at all because they are so low on oxygen. The first problem we're going to talk about with the respiratory system is ear infections. So ear infections may seem a little odd to be in this module, but basically we're saying it's connected to the nasopharynx, and it's very common for children to get ear infections. So it's one of the most common childhood illnesses that accounts for millions and millions of antibiotic prescriptions. So otitis media is basically a fancy word for an ear infection. Ear infections can be either bacterial or viral. They're most commonly bacterial. Things like strep pneumoniae, Haemophilus, influenza, but can be literally anything. Some of the signs of an ear infection can be the child says that their ear hurts. If they are too young to be able to verbalize that, such as babies, they may be doing things like pulling at their ears or messing with their ears frequently. If we were to look in their ear with an otoscope, we would see that their eardrum is bulging and red. They may have drainage. It could be yellow or green. It could be foul smelling. They could have other non-specific signs of infection, so things like a fever, crying, not wanting to eat, not sleeping very well, diarrhea, things like that. And one of the things we want to educate them about, or their parents, is to make sure that they are finishing their antibiotics. Another similar problem is called otitis media with effusion. This one's also very common, but it may or may not have an infection that goes along with it. Basically, what it is a collection of fluid in the middle ear. So this collection of fluid can cause pain, it can cause tinnitus, it can cause hearing loss, sort of a feeling of fullness in the ear. They may have mild dizziness or a mild inability to maintain balance. So usually for this one, they prescribe something to dry it up, so like Claritin or Zyrtec or something like that. If there is an infection that goes along with it, then antibiotics will also be prescribed. Another similar infection or like infection is otitis externa, which is sometimes just called swimmer's ear. So this one is inflammation of the external ear canal. So frequently it is involving the pinna or the tragus area. So there may be swelling and tenderness if we are palpating those areas. Sometimes it can also affect the tympanic membrane, and there could be an infection associated with it that's usually bacterial, and usually they will have drainage if they do have that associated infection. So since ear infections are so common in children, and they are more common in some children than others, if a child does have recurrent ear infections over and over again, sometimes the provider will prescribe a tympanostomy, which is basically the tubes in the ears. So they're little tiny tubes that are actually placed in the tympanic membrane, so they actually have to make a little cut in the tympanic membrane. The little tube is placed in that cut, and it helps to relieve pressure in the ear, and it helps with drainage. These usually fall out spontaneously within about a year. Another word for these, if you see it, is called pressure equalizer tubes or PE tubes, but frequently we just call them ear tubes. Tonsillitis is the next problem we're going to talk about. So tonsillitis is basically inflammation of the tonsils. We also include the adenoids in here as well, which aren't pictured in this drawing because you can't really see them when a person opens their mouth. But both the tonsils and the adenoids are lymphoid tissue that is basically in the back of our throat. So tonsillitis can be either bacterial or viral. So the child could have something like strep throat, but they could also have something like the flu or RSV and also get tonsillitis from that. Symptoms of it are going to be a sore throat, red tonsils. They could also have white exudate on their tonsils. We can grade tonsils by how severe they are, talking about like how swollen they are, basically. So a grade of +1 or +2, like you can see on the left side of the screen, is considered normal. Once we get to +3, that's considered enlarged, and typically we suspect that they have some sort of infection. Grade 4 is significant swelling, where the tonsils on each side of the back of the throat are almost touching. So the child could also have difficulty swallowing. They could be snoring at night when they're sleeping. They could be so enlarged that they're affecting their speech. If the child does have trouble swallowing or they absolutely cannot swallow, then we should educate the parents to seek care immediately for safety reasons. So if the child does have recurrent and chronic tonsillitis and chronic inflammation, the provider could schedule a tonsillectomy and an adenoidectomy. Frequently, we just call that a TNA because we don't want to say all of that. So basically, they just remove the tonsils and the adenoids so that they don't become inflamed like this. Otherwise, it's treated with antibiotics as normal if it's a bacterial infection. But after their TNA, we want to make sure that we're putting the child side-lying, especially if they are still sort of sedated from the procedure, because we want, if there's any drainage, we don't want it to be going all the way into the back of their throat. So we want them to be on their side. We want to do very gentle oral assessments so that we are not disrupting the surgical site. And we want to be looking for things like bleeding, or is the child swallowing continuously? If they're swallowing continuously, it could be a sign that they are bleeding. So basically they're continuously swallowing their blood. Depending on how old they are, they may not be able to verbalize, or they may not know that it's blood that they're swallowing. We want to avoid red foods because we are going to assess for bleeding. So frequently after a tonsillectomy, we'll give a child popsicles, ice chips, Jello, things that are very easy to eat, but we want to avoid red colored foods like that. So you choose blue or green or something else. We also want to look for any bleeding. So if they do have dark brown blood in the back of their throat, that's expected and considered normal. Dark brown blood is sort of like old blood, so that's okay. We just don't want to see frank, bright red blood. So if we do see that, we would want to notify the provider. We also want to avoid foods that are acidic or spicy. So any sort of spicy food, and then also things like, say, orange juice. We want to prevent them from doing things that's going to increase pressure in the back of their throat. So avoiding things like vomiting, coughing, blowing their nose, even crying or using a straw. So basically we want to make sure that we are treating even mild pain to minimize things like crying and things like that, and educating them to not do things like blowing their nose. Also, after the procedure, because of the surgery, they may, for a short period of time, have a hoarse voice and be sort of nauseated from any drainage that they are having. But we do want to encourage them to take pain medication, basically so that they can continue to eat, because we don't want them to go a long period of time without eating. Another problem that goes along with GI as well is atresia and fistulas. So this is usually going to be diagnosed either prenatally or right after a baby is born. So this is basically exclusively for infants. But we can have esophageal atresia and a tracheoesophageal fistula, also called a TEF. So an atresia is basically where something didn't form correctly and there's some sort of blockage. So like in this instance, the esophagus doesn't continue its formation all the way down to the stomach. And then a fistula is where there's basically a new route that something has taken. So in this case, again, it's usually the esophagus that takes a wrong route and is attached to the trachea. So when humans are developing, basically the esophagus and the trachea begin as one single tube, and then after a certain time period, they differentiate and split off into two separate tubes. If there's some problem during this time of differentiation and they don't split correctly, then we can have esophageal atresia or the TEF. So depending on which type they have, so if you're looking at the graphic on your screen, there's a bunch of different things that can happen, and there's different types of this that can happen, maybe dependent on what symptoms the baby has. Again, this can be diagnosed prenatally on ultrasound, but it could be missed because it's probably not something that they're typically looking for. So if it's not diagnosed prenatally on ultrasound, some different things can happen. So we could have respiratory distress. So if you're looking at these graphics and you're looking at the one, say the bottom left-hand corner one, where the esophagus is just going straight into the trachea, think about when the baby starts to eat, either breastfeeding or bottle feeding, basically the milk is going to go straight into the trachea. So they're going to have respiratory distress. They could have cyanosis during their feeding. They could also have vomiting and coughing during the feeding. They could also have that one with that top middle picture where there is an atresia and basically the esophagus isn't going anywhere. It just kind of ends blindly in a pouch. So basically the baby starts eating, the milk has literally nowhere to go, so they're going to pretty quickly start vomiting and possibly coughing. They could also have abdominal distension, for example, in the bottom left-hand picture, where basically there's nothing going to the stomach. Gas and things can build up in the stomach and they could have distension. They may have excessive oral secretions. Basically, this is life-threatening and it's an immediate need for surgery. So they will basically immediately be going to surgery where it will be repaired. So croup is a general term referring to the inflammatory process and the symptoms that all go together to make up croup. It's not necessarily one specific virus. It is usually viral. The most common one that causes croup is parainfluenza, but it could also be caused by any of the other viruses like RSV or adenovirus or the flu. Usually the child will have a sort of mild upper respiratory type symptoms preceding croup. So they might have, a runny nose or a mild cough, and then it sort of turns into croup. It's most common in babies and toddlers ages 3 months to 3 years, so older children usually are not diagnosed with croup. One of the hallmarks of croup is the cough. So it's a seal-like barky cough. It literally sounds just like a seal, and it's usually worse at night. So they may not even be coughing through the day or just very mildly, but once you get to nighttime, they're coughing all night long. It's usually worse also in the winter months. They may also have inspiratory stridor, so you may hear like a crowing type sound, also without a stethoscope, so parents could report hearing this as well. They may have mild respiratory distress, so things like being restless, they may be retracting, may have nasal flaring. They may or may not have a fever. If they do, it's typically pretty low, not a high fever. We can increase fluids. So if they are at home, the provider could basically educate them to try to drink more. If they are hospitalized, then of course they could be on IV fluids. They may also need high flow nasal cannula, which is basically just like a nasal cannula, but it usually has extra humidity and then of course a higher flow. Another common treatment, especially for hospitalized kids, or possibly if they're just in the ER, is giving them an oral corticosteroid, dexamethasone. And they could also get inhaled epinephrine, which is also called racemic epi. So this is if it's moderate to severe. The racemic epi basically is a bronchial smooth muscle. It relaxes the bronchial smooth muscles and bronchodilates. So basically they can get more air in. If they are at home, we can recommend a cool mist humidifier. Also a very common sort of home treatment, which this isn't cool mist, it's more like warm mist, but is getting a steamy shower ready in the bathroom. So basically the child doesn't have to be in the shower like under the water, but basically just making all the steam in the bathroom and sitting in there with the child. Epiglottitis is basically an acute and rapidly progressing inflammation of the larynx and epiglottitis that can be life-threatening. So this usually affects kids that are about 2 to 8 years old. It's usually caused by bacteria. Haemophilus influenza type B is the most common cause. This is a little bit more rare now than it used to be because we do have a vaccine for Hib, but a lot of people probably are refusing this vaccine because they probably don't even know what it is. So it's not totally eradicated, but it is something that can be very dangerous that we need to look out for, even though it is less common than it used to be. So if we're describing the symptoms of epiglottitis, usually we can describe it and say that the symptoms are characterized by 4 Ds and an S. So the child usually has drooling, dysphagia, dysphonia, distressed inspiratory air movement, and stridor. It's sort of the same thing. So for this one, if a child comes in with these symptoms, we want to automatically think that they may have epiglottitis, which can be sort of an emergency situation. So we would want to notify the provider. Another thing that we need to know about this is that we probably would want to automatically assess them. But for this one, once we know these symptoms, we actually don't want to inspect their mouth or their throat unless we have the ability ourselves to intubate them, which usually as an RN you do not do. So we don't want to look at their mouth or their throat, so we don't want to have them open their mouth, look in there with a pen light, or use a tongue depressor or anything like that without intubation supplies literally ready to go. Because if we do stimulate the back of their throat or anything in their throat, it could lead to laryngospasms or bronchospasms, which can lead to completely closing off their airway. So basically it's like their throat just spasms shut all of a sudden, and then we're not going to be able to get an ET tube through that because it's just completely closed. Before they come in with these symptoms, they could have things like a sore throat as well, tachycardia, they could have a fever. The child could also be sitting in positions that we think of with respiratory distress, like a tripod position, or they just look like they are struggling to breathe. So we basically want to keep the child very calm. So we want to encourage them not to cry. We don't want to basically make them agitated in any way. So sometimes with these children, they may take them straight to the OR to intubate them. Because if we even try to put in an IV in a child that's say 3 years old, they're probably going to start freaking out and crying. So they may have to go to the OR to get basically inhaled anesthesia, and then the anesthesiologist can put in their IV, and then they can basically intubate them sort of all at the same time. But if we are looking at this picture on your screen, the basically larynx on the left side is normal, and the one on the right is epiglottitis. So you can see they do have an ET tube in, thankfully, but everything is basically swollen around it. So if that ET tube wasn't in there, basically the child could not breathe at all. Bronchiolitis is acute inflammation of the bronchioles. This is, again, another sort of broad term that is used to describe these symptoms in children. It's usually children younger than 24 months that also have wheezing. And it's usually viral, but it can be caused by a bunch of different viruses. So RSV, rhino, parainfluenza, adenovirus, influenza, basically any virus you could think of can cause bronchiolitis. RSV is probably the most common. So if you're at clinical, a lot of times the diagnosis will be RSV bronchiolitis. But what happens with this is that the virus basically enters the mucosal cells in the respiratory tract and it ruptures those cells. So it creates like debris and increased mucus production. So basically with bronchiolitis, there's a whole bunch of mucus. So symptom-wise, the child usually has wheezing and crackles from all this mucus in their lungs. Also, typically, they have nasal congestion, so horribly runny nose, also very clogged, snot and boogers basically everywhere. Depending on how old they are, especially with babies, apnea can be common. So if you think of kids, this is kids who are usually less than 2. They typically don't know how to blow their nose, and even if you try to teach them, they can't really do it. So they can be hospitalized basically for suctioning and sometimes supportive care. They may need oxygen as well, but a lot of times they literally cannot clear their own mucus, so they can't protect their own airway in any way. So if it's very severe, they can be hospitalized. They could also have a low-grade fever. They could have a cough. Tachypnea is very common. If they are very tachypnic, they may not be able to eat orally, and they may have an NG tube for feedings. This can progress to severe respiratory distress and respiratory failure. So they can have some of those symptoms that we talked about on an earlier slide, like not being able to cry or talk, things like that, increased tachypnea, increased tachycardia as well. Some treatments for this. One treatment is nebulized hypertonic saline. So instead of the little saline bullets that are 0.9%, these are 3%, so they're hypertonic. So it's not actually a medication, it's just saline. But what it does is it basically, and when it's nebulized by osmosis, it helps to shift water into the mucus in the lungs. So it basically helps to thin the secretions out. We can also use CPT, positioning the patient so that their mucus can drain out appropriately. If they are admitted, they're probably going to be on IV fluids for hydration. They are probably going to be on supplemental oxygen. If they do progress to severe respiratory distress or respiratory failure, these children can progress all the way to intubation. But if you walk into a child's room and they are sort of just mildly desatting, so maybe they're 89%, the first thing you want to do is basically suction them. So we can suction them just from their nose with a little nasal suction, or even deep nasal pharyngeal suction you could also do if it doesn't clear just with nasal suctioning. So typically, like I said before, since these kids can't blow their own nose, if we just go in and suction them, that usually corrects the desatting. So basically you're doing that first before you're, say, turning up their oxygen percentage or their oxygen flow, or calling the provider or the RT or whatever you need to do. We don't typically have humidifiers in the hospital, but if they are at home, one thing we can recommend is a humidifier. Respiratory distress syndrome, also called RDS, is an inflammatory process that's exclusively related to the underdeveloped lungs and surfactant deficiency of premature babies. So this primarily is going to occur in babies that are less than 34 weeks gestation. Almost all babies that are born at 28 weeks or earlier will automatically be diagnosed with respiratory distress syndrome, but it's extremely common in preterm babies. So what surfactant is, if you don't already know, it basically prevents the alveoli from sticking together when the baby exhales. So if they don't have the surfactant, or if they don't have enough of it, it can cause basically like stiffening of the lungs. So the alveoli can become edematous, they can collapse, and they basically have increased airway resistance. So they're basically not able to take as good of breaths as we would like. The alveoli are basically going to collapse. So symptoms of this are tachypnea, retractions, especially intercostal and subcostal retractions, nasal flaring, cyanosis, grunting. If we auscultate, we would hear fine crackles or diminished breath sounds or both. On a chest x-ray, it's described as having a ground glass appearance. So if you're looking at this chest x-ray on your screen and you think of sort of like the type of old style shower doors that appear to have glass that's sort of like ground, that's sort of what it looks like. You don't need to identify on the test or anything like that x-rays, but just know that it has a ground glass appearance. So if you were reading the x-ray report from the radiologist, they typically always will write ground glass appearance if the baby is diagnosed with RDS. Thankfully, we can treat this with giving the baby more surfactant. So they're lacking it, so we can basically give them more. So there are surfactants that are made from pigs. There's also ones that are made from cows or are synthetic. If because of religious reasons, they can't use the one from pigs. But basically, we can put in an ET tube and bag down the surfactant through the tube to get it into their lungs. So it's basically like a liquid, a very small amount that you're putting into their lungs. And basically it's going to distribute throughout all of their lungs as you're bagging it in. Depending on how severe the RDS is, they might need higher level oxygenation, such as CPAP, or they could need mechanical ventilation, where we're just going to leave that ET tube in for a while. We're also going to do frequent respiratory assessments and monitoring, so they're going to be admitted to the NICU or the PICU. We're going to be doing respiratory assessments every 3 hours at the minimum. Bronchopulmonary dysplasia, also called BPD, is related to respiratory distress syndrome because the babies that are eventually diagnosed with BPD had respiratory distress syndrome as a premature infant. So this is a chronic respiratory disorder in premature infants that's treated with a high concentration of oxygen and possible mechanical ventilation. It's the most common lung disease of infancy. So almost half of preterm infants that were born at less than 29 weeks will be diagnosed with BPD. So basically, if we are giving infants a high percentage of oxygen or are mechanically ventilating them for a long period of time, it's going to injure the lungs and scar the lungs. It can also lead to what's called pulmonary hypertension. So this happens when the pressure in the blood vessels that are leading from the heart to the lungs is too high. So these blood vessels develop an increased amount of muscle, like in the wall of the blood vessels. So the heart pumps the blood from the right ventricle to the lungs to get oxygen. And when the pressure in that artery gets too high, then the arteries in the lungs can narrow, and then the blood basically doesn't flow as well as it should, and then there's going to be less oxygen in the blood. So these babies typically don't have very good endurance and tire easily. Usually they are diagnosed with BPD once they reach their gestational due date and they're still on oxygen. So say the baby was born at 30 weeks and now it's been 10 weeks and now they're corrected to 40 weeks gestation and they're still on oxygen, they usually basically automatically get diagnosed with BPD. So once they're ready to go home, if they're still on a very low amount of oxygen, they may actually be discharged home on oxygen. So if you see a baby out and about and they're on oxygen, they probably have BPD. So when they are hospitalized and even when they're home, we want to make sure that we are taking care of their activity intolerance that they might have. So we want to cluster their care. So this is common in the NICU, where say every 3 or 4 hours, whatever is ordered, we're going to go in and do everything that we need to do at one period of time, and then we're going to let them rest until the next care time. So we're going to go in, say it's 9 o'clock and it's their time. We're going to go in and do our assessment, do their vitals, change their diaper, give them their feeding or feed them if they're feeding orally. Their parents may hold them at that time if they're there. And then basically after that, until their next care time, which say is at noon or 1 if it's 4 hours, we're just going to leave them alone. So obviously if they need something, we're going to get that for them. So if they start crying, we're going to attend to them. If they start desatting, we're going to attend to them. But otherwise, we're not just going to go in and touch them. So we're not going to go in and change their diaper randomly in between that time. Basically, it just is allowing for a long period of rest so that they can rest up to the next time that they need to eat and basically grow. They also typically have poor weight gain, so we may be adding more calories to their breast milk or their formula. So most breast milk or formula is around 19 or 20 calories, and we're going to add more to that. Like I said before, they might go home on oxygen, so there's little oxygen concentrators that babies can have, and of course, little oxygen tanks. These babies are at high risk for getting sick with respiratory illnesses that then need to be hospitalized. So RSV is usually the worst of them. So there is a monoclonal antibody injection that can be given to infants that qualify. So usually they have to be born less than 29 weeks gestation. There's some other qualifiers that they could get as well. But basically it's sort of like a vaccine, but it's monoclonal antibodies. So it's called Synagis is the brand name. I can't pronounce this generic name, but basically it helps to prevent RSV. The injections don't last very long, so they do have to get them once a month during RSV season. So in the fall and winter, whenever they determine that RSV season has started, the baby basically has to get this injection monthly to help prevent RSV. Congenital diaphragmatic hernia, or CDH for short, is caused by an incomplete diaphragm formation. So basically somewhere in the diaphragm, it doesn't completely form, so there is a hole in it. So whatever is below it there can come up into the chest cavity. This often affects the left side. So like in this x-ray, it's affecting the left side. This is life-threatening, where the baby is going to be, at the very least, in respiratory distress, if not respiratory failure, where they're going to be tachypnic, have nasal flaring, retractions, cyanotic. So they are typically going to be intubated. They may be tachycardic, and their heart sounds may be shifted to the right side of their chest. Again, it's depending on which side is affected. This is also associated with pulmonary hypoplasia, meaning that the lungs, or possibly one of the lungs, doesn't form correctly or fully. So in this x-ray, you can see that the baby's intestines are all the way up on the left side of the chest, extending like all the way as far as it'll go to the top. So we can't see that left lung in this x-ray, so we don't know at this point, is it fully developed? Is it the normal size? Is it there at all? this bowel is taking up so much space, and if it's been there for a long period of time while the baby is developing, then the lung can't develop to the correct size. So this is also going to play into why they're having such severe respiratory distress or respiratory failure. So they may have irregular chest wall movement because of this also. So like with this baby, the left side of the chest may not be moving as we would expect because the lung may be hypoplastic. They may have decreased breath sounds on that side or none at all. You can also hear bowel sounds in the side that is affected. Again, it depends on what is going up through the diaphragm. So if it was a right-sided CDH, then the liver may be up in the chest, and then you wouldn't hear bowel sounds from that. So you wouldn't hear bowel sounds in the chest in that instance. They may also have a scaphoid abdomen. So if you're looking at this x-ray and you see all of these intestines are basically up in the baby's chest, then there's going to be less structures in the abdomen, so it can actually appear very sunken in. So looking at this x-ray, it looks like the liver and maybe part of the stomach is down in the abdomen, so there's not going to be like a whole lot in the abdomen. So they need immediate respiratory support, so they're probably going to be mechanically ventilated, and we're going to be preparing for surgery almost immediately as well. So asthma you've learned about before in adults, very similar in children, some of just the treatments may be a little bit different. But asthma is a chronic obstructive inflammatory disorder. It's caused by hyperresponsiveness of the airways. We can have airway edema, narrowing, and mucus production. Usually, each specific person with asthma has specific triggers that may cause an asthma exacerbation or an asthma attack. So it could be things like smoke, getting sick, cold air, exercise, pollen, dust, pets. It could be literally anything. So the person can have bronchospasms that can occur from constriction of the smooth muscle in their bronchioles. We can have inflammation of their mucous membranes that causes an accumulation of secretions, so a lot of mucus and secretions in the airways. We can have contraction of the smooth muscles, swelling, and mucus that all can obstruct the airflow and cause an obstruction, which is basically an asthma attack or an asthma exacerbation. On assessment, the child can have a non-productive or a frothy cough that is typically worse at night. They may present with the sole symptom of cough. A night cough may also signify the need for advancing therapy, so like changing their medications or adding medications. They can also, of course, have shortness of breath, chest tightness. We would expect wheezing. They also may have a prolonged expiration. There is a high prevalence of asthma in food allergic children, especially egg and tree nut allergies are the most prevalent. They may also have a history of other types of allergies and like allergic rhinitis and eczema as well. They may have retractions, accessory muscle use, nasal flaring. They could have a barrel chest if it is chronic and they're an older child. If we are auscultating and we don't hear any breath sounds, the absence of breath sounds, that's ominous. Also, if their breath sounds sound coarse. So if you can sort of picture in your head, the airway is so constricted and tight that it's almost sort of like the sides of it are rubbing together and it makes sort of a coarse sound. So it's like it's so constricted, it's not even, you don't even hear wheezing anymore. It's just this coarseness or sort of like rubbing together harsh sound. That is ominous, where we may be anticipating their airway being completely closed off. Diagnosis of asthma is usually based on symptoms, but if we were to get a chest x-ray when they're having an asthma attack, it may show hyperinflation. If we were to get an arterial blood gas during an asthma attack, it may show hypoxemia and hypercapnia. There's other pulmonary function tests that can be used to diagnose asthma or to exclude other possible diagnoses as well. A peak flow meter isn't diagnostic itself. It's used to monitor therapy, but what it does is it measures the ability to push air out of the lungs. So basically the child is going to exhale into this device as hard as they can. So they'll have a sort of personal best number. So it's the best level that they got when they exhaled into it as hard as they could when they were in optimal health. So not during an asthma exacerbation, not when they're sick or anything like that. What's the highest number that they ever have gotten? And then they're going to have these other ranges that are set on the peak flow meter. You can see on this picture there is a red zone, a yellow zone, and a green zone. And those zones are going to tell them to do different things, which is going to be on the next slide. We're going to basically make an action plan that's based on these color zones. The provider can also recommend allergy testing to identify the triggers if it's not readily apparent and if the child does have a history of other allergies. So this is an example of an asthma action plan that goes along with the peak flow meter. So basically the provider, along with possibly an asthma educator or someone in the unit or at the doctor's office, is going to help fill out this asthma action plan, which is going to help kids and their parents know what to do based on certain symptoms and what the number that they get from their peak flow meter. So if they're in the green zone, that basically means they're all good. So basically they blow into their peak flow meter and they get a number in their green zone. They basically use their daily controller medication if that is prescribed, and they can go on with their normal day-to-day activities. If they're in the yellow zone, then that's sort of like the caution zone. So they're still going to use their preventative medication that's listed in the green zone, but then they might add something else. So something like an albuterol if they're having other symptoms as well. So maybe they're wheezing and they feel like they have a tight chest and they blow in their peak flow meter and are in the yellow zone, then maybe it'll say use your albuterol inhaler, however it's prescribed. The red zone then is the danger zone. So basically they might have other specific medications or a nebulizer or whatever it may be, but they also need to, at the bare minimum, call their doctor, if not go to an urgent care or an ER immediately. So usually they're going to have more severe asthma symptoms. They might have trouble talking, for example. They might be retracting. And also when they blow into their peak flow meter, it's in this red zone. So basically they're not moving air very well at all. So basically this just helps parents, especially if it's a new asthma diagnosis and older children as well, know what to do if they're having certain symptoms or if they are getting a certain number on their peak flow meter. So interventions for asthma, if they are hospitalized, obviously they can be on oxygen if needed. Also, bronchodilators such as albuterol are frequently prescribed. A review on metered dose inhalers and how to use them, or how to educate people to use them if you need to do that. Make sure that we're shaking it before use. Also, they want to take a deep breath before actually taking the first puff. But when they take the first puff, we want to tell them to inhale it in slowly and then hold their breath for at least 10 seconds and then also slowly exhale. If a second puff is prescribed, they want to wait about 60 seconds between puffs. They want to rinse their mouth out afterwards, especially if the inhaler has a steroid in it. So not necessarily an albuterol inhaler, it's not as important, but steroid inhalers are going to put them at higher risk for thrush. So we want them to rinse out their mouth. They can also use a spacer. So the spacer, like pictured here, can help deliver the medication quicker, and it can also help little kids to coordinate the breathing and the puffs together. So it's sort of like the medication gets trapped in the chamber, so they don't lose all the medication if they don't take the breath at the right time and things like that. If we are giving them a nebulizer, and they can also have a home nebulizer as well, we want them to sit up straight in high Fowler's position or near that and take deep breaths so that they are breathing in the medication deeply while it's being administered. The focus of asthma is on prevention of exacerbation, so preventing asthma attacks before they even start. So we want them to make sure that they are taking their preventative medication regularly, even when they don't have any symptoms, because that basically means that the preventative medication is working. Apnea is defined as cessation of breathing for greater than 20 seconds. It can also be any cessation of breathing that's accompanied by cyanosis, bradycardia, pallor, and hypotonia. So it could be they stop breathing for, say, 15 seconds, but they have these other symptoms along with it. Could also be called apnea. So this happens a lot with premature babies. It's called apnea of prematurity. Occurs in most infants less than 28 weeks gestation, usually resolves by around 36 weeks corrected. So it's sort of like their brain just forgets to remind them to breathe. It can also, though, be affected by other things like thermal instability. So if the baby is too cold, they can have apnea. If the mother used drugs, especially opiates, they can have apnea, or if they're not getting enough oxygen. So maybe they need to be put on oxygen, or if they're already on oxygen, it may just need to be a higher flow. The treatment of choice is non-invasive positive pressure oxygenation, which is basically CPAP. Another treatment that's very easy is caffeine. So we can give babies caffeine either intravenously or orally. So the caffeine basically stimulates their respiratory drive in their brain to sort of like remind them to breathe. The apnea can also be an early sign of sepsis or respiratory illness. So a very early sign, maybe they just caught something and they're starting to go apneic, it can be one of the first signs. This is different than periodic breathing of the newborns. So like we said on a previous slide, they may have apnea up to 15 seconds, and that's considered normal. But this is usually longer than that or associated with other symptoms like bradycardia and things like that. We want to make sure that we are positioning babies so that their airway is open. So we don't want them to be chin to chest. So we could have like a neck roll on their neck if needed. There's also special positioning pillows and things like that for premature infants to help keep their airway open. We also want to stimulate the infant. So if they do go apneic, if they're on a monitor, say the monitor is alarming because of apnea, maybe it's alarming because they are desatting or because they're bradycardic. Basically, we want to go over to the infant and stimulate them in some way. The most common way is to just rub their chest. So sort of like a sternal rub, but not as aggressive as that. You can also do things sort of like gently pinching their toes. Basically, it's sort of like you're trying to wake them up and make them take a breath. Sometimes babies can be discharged with an apnea monitor, which is essentially just a pulse ox machine. It's not very common that this happens, but if it does, we want to tell the parents to make sure that they keep it on them at all times, except for, of course, when they are bathing or when they're changing out the probe. An apparent life-threatening event, ALTE for short, also sometimes called a brief resolved unexplained event, or BRUE, is an episode of apnea that affects infants younger than 4 months with a gestational age of 37 weeks or older. So basically they are not premature, but they're basically newborns. So this is where it's sort of like a scary incident, but the baby thankfully doesn't actually die. They do have a period of apnea where they do have color change, hypotonia, and they could have actual choking. This one's different than SIDS because, again, they don't actually die, and 50% of the cases occur during wake times, so they're not even asleep. Potential causes for this are things like, are they refluxing when they're eating? Are they sick with a respiratory infection? Did they have a seizure? Are they aspirating when they're feeding? Do they have a heart defect, or is there child abuse? So with these feeding ones, like if they're having reflux, do we need to do something like optimal feeding positions, medication for reflux, making sure we're doing things like holding them upright after feeding so that they're not refluxing? Or if they are aspirating, that could just be a one-time thing where, say, the baby accidentally gets milk into, their trachea, their lungs. So basically, when babies do that, they automatically sort of just stop breathing because they're trying to protect their airway, but it sort of might be a little bit too late. So sometimes this can happen when they are trying to protect their airway, but then they just stop breathing altogether. They could also be prescribed an apnea monitor if needed, but we want to make sure that they do have safe sleep practices and that they are being fed appropriately and have appropriate interventions for any of these other possible causes for this. So there are dosage calc questions about maintenance fluid requirements on exam 2. So you will need to memorize this chart to figure out what is a child's basically IV fluid maintenance requirements for the day. So if they're less than 10 kilos, that one's pretty easy. It's just 100 milliliters per kilogram per day. So a pretty easy calculation there. If their weight is between 11 to 20 kilograms, we're going to start with 1,000 mils, and then we're going to add 50 mils for each kilogram that is above 10. Then if they're greater than 20 kilograms, we're going to start with a base of 1,500 mils, and we're going to add 20 mils for each kilogram that's greater than 20 kilograms. So on the example on your screen, it says calculate the daily fluid requirement for a child weighing 25 kilograms. So they're over 20, so we're going to use that last row on the table. So we're going to start out with 1,500 mils just at the beginning, and then 25 minus 20 is 5. So we have 5 extra kilos that we need to account for here. So we're going to do that 20 mils per kilo times 5 kilograms, which gives us an extra 100 milliliters. We just add those two together and we get 1,600 milliliters. So here is another example of basically 2 different examples of maintenance fluid requirement questions that could be on the exam. So the first one is basically the same as on the last slide, but just with a different weight. The second one on here is just a little bit different because you're just going to do one more step. So it says now calculate the hourly maintenance fluid requirement in mils per hour. So basically with the first part of this question, you're just going to get an answer. Just 1,250 mils is the answer. So that's going to be the answer for that one. So that's basically for the entire day. So the child that weighs 15 kilograms is going to need 1,250 mils for the entire day. But if it asks you to calculate the fluid requirement in mils per hour, all you have to do is divide that by however many hours are in a day, which is 24. So to get that answer, you are going to divide 1,250 by 24, and you get 52.1 mils per hour. And this is worked out on the next slide.